Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington, and I wanted to talk about some of the clinical implications of the different subgroups who were studied in the KEYNOTE-189 trial of chemotherapy with either pembrolizumab or placebo in a non-squamous non-small cell lung cancer population without a driver mutation. I've covered the key highlights from this study in terms of efficacy and tolerability in a prior video. There's other sources. I'd encourage you to look at those. Today and now in this video, I'm really just going to focus on what the implications are for the subgroup of patients, about a third of them, who we test for PD-L1, who have 1 to 49% tumor PD-L1 expression or tumor proportion score. So the study design is shown here. 2/3 of patients getting carbo or cis with pemetrexed and either pembrolizumab, and 2/3, 1/3 getting placebo instead. In the chemo arm, you could cross over to pembrolizumab upon progression. About half the eligible patients did. When we look at the subgroup of patients with PD-L1 tumor proportion score 1 to 49%, you could see that there's really a convincing benefit for the patients with who got the chemotherapy pembrolizumab combination relative to chemo and placebo. This is reflected in a more than doubling of the response rate, as well as very clear separations of the curves for both progression-free survival and overall survival that's really sustained over time, and I would say very clinically significant as well as being statistically significant here. I think the challenge, however, is that, of course, when you're giving this combination, you have the combined side effects of both the chemotherapy backbone and the pembrolizumab. And the fly in the ointment here is a competing potential standard for these patients with pembrolizumab monotherapy. This is the KEYNOTE-042 trial study schema. Over 1,200 patients with either squamous or non-squamous histology and with a PD-L1 level of at least 1%, but this includes also the patients with high-level expression of 50% or greater. Now, this trial randomizes patients between pembrolizumab and histology-appropriate chemotherapy. It's really the same basic trial design as the KEYNOTE-024 trial that had narrower eligibility and enrolled patients with PD-L1 of 50% or greater, now including about 2/3 of the patients instead of just 1/3 of the patients we test. And we know that this study is positive for an overall survival benefit based on a recent press release. But we haven't seen the actual data yet. I'm hopeful, expecting we'll see that at ASCO 2018. And this will be very important to see how much of the benefit is propelled by the patients with the highest level PD-L1 who are already standardly getting pembrolizumab monotherapy, namely those with a 50% or higher tumor proportion score. If we see that the patients with lower level PD-L1 but still positive at 1% or greater are still benefiting significantly with pembrolizumab, I think that the KEYNOTE-189 chemo-immunotherapy combination is likely to be less favored than pembrolizumab monotherapy. However, we don't have these data yet, and we're really just speculating. We also don't have an FDA approval for pembrolizumab monotherapy in this broader population at this time in April of 2018. We do, however, already have an approval for carbo, pemetrexed, and pembrolizumab that was included in KEYNOTE-189. The FDA approval came in May of 2017 based on a randomized phase 2 trial of carbo-pem-pembro versus carbo-pem. That was KEYNOTE-21G. That hadn't historically been widely adopted because it was still just 123 patients and hadn't shown a clear survival benefit. but it has been an option to use, and I think it will be increasingly used now, particularly for patients with low or negative PD-L1 expression, more than for the patients with high-level PD-L1. So we will get more information, I hope, very soon when we see the actual data from KEYNOTE-042. In the meantime, I think that the chemo-immunotherapy combination with carbo, pemetrexed, pembro is going to be an attractive option for eligible patients. I welcome your thoughts on this. I hope you'll add your objections, comments, questions on the page, and I also would welcome you to like, comment, and subscribe to the videos. Thanks. I hope you find that helpful. And I'm going to turn to the question of the PD-L1 subgroup of less than 1% as the last video on the KEYNOTE-189 trial.